Hi, my name's Danielle Loeb. I am a associate professor in GIM. My clinic is over at Anschutz Internal Medicine, so kind of the sibling clinic to this clinic. And I have been implementing trans care. I started there. We did it at the Wish Clinic, which is sort of nice to know about because they've had some education on cultural competency and stuff if your patients need procedures done. And right now I'm doing it here and at Cherry Creek. So residents are kind of fundamental to this because you're often seeing new patients more than other people. And you might be sort of educating it's a unique opportunity because you may be learning this along with your attendings. So everybody's learning together. So gender affirming hormone therapy for the general internist. This talk is informed in a lot of ways by endocrinologists here at University of Colorado. And I have no financial conflicts of interest, but know that most things discussed here, unless I'm referencing a study, is often expert opinion. And the meds are often off-label. So what will we do? So by the end, my learning objective is that you would be able to feel somewhat confident in having an approach to starting gender-affirming hormone therapy. And basically recall monitoring strategies, although I have a whole slew of reference materials and there's the pathway, so you don't have to actually keep it all in your head. But it's actually, hopefully what you would get out of this talk is knowing the why of it. Like, why are you doing the monitoring? You might forget exactly what and have to go look it up, but I want you to, like, when you look it up, to understand why and what you might do with what you find. And then some of the risks and benefits of hormone therapy. So there's 3 main guidelines. And then there's a lot of others too, actually, of like centers that make their own guidelines. There's the WPATH, standards of care, and they set a lot of it's almost sort of political aspects of things, like, should you have a mental health letter before starting hormone therapy? Like, should that be required? Which, is getting taken away, has been, I mean, people are largely not doing it anymore, but they set a lot of those standards. And then the Endocrine Society is what we use here. It's more conservative, I would say, in terms of like values of levels of hormones and things like that, but that tends to be our reference for in this talk and on the pathway that we're using. And then there's the UCSF guidelines. They're very user-friendly and they're written quite nicely. They're nice to share with your patients sometimes when you're deciding what to use, what method, what route of hormones you'd like to use. So they're very helpful. All right. So this is a little bit about the why. So this is from a qualitative study, and this patient is talking about his experience that wasn't great in a healthcare setting. And so this Black trans patient encountered a provider who wasn't very sensitive. And so this is him. I actually spoke to her afterwards. You're going to have more clients like me. What are you going to do for best practices? These are unacceptable standards of care. And she was explaining to me, well, this is the first time something like this has happened. And he's like, granted, but you need to prepare yourself for different types of people walking through your office. So that's what we're doing. Hopefully, I know some of you are actually, interested and engaged and want to provide this care, but at the very least, it's, you're gonna provide this care. Even if you're headed towards cardiology, like, we really need you to be able to do this and understand it. So a little bit about terminology. So gender identity is how someone self-identifies. It may or may not have anything to do with how they appear externally. It may or may not have anything to do with how they were assigned at birth. It's an inner thing. So whatever someone says their gender identity is what their gender identity is, like, period, because that's by definition, it's how they identify. And then sex assigned at birth, please don't say biologic sex. It's what someone assigned them at birth, is based on however they decided to put something on the birth certificate, whether it's external genitals or chromosomes, based on that. Then gender forming hormone therapy are like meds, and gender forming surgery are procedures to affirm gender. So this webpage, if you kind of put into whatever search engine you use, CUSOM gender, you'll probably get it. And it has like a page of dot phrases you can put into your notes that'll capture like all the HPI you need, plans, et cetera. It has quick guides to providing hormone therapy. It has cross cover. It's really useful if you're doing cross cover, and just to have that up, you know, as you start to see more and more trans patients. So they were made for you. They were made for us. And so it's under resources, clinician resources. So initiation of gender forming hormone therapy. So what are you going to do with any patient that comes in saying, I want hormones? So you're going to talk to them about their goals. This is really open-ended. Like, why are you here? What are you interested in? What are your goals? Like, it's an area where it's really, really important to go back to the kind of medical interviewing you were taught in med school that you may have sort of wandered away from in residency for efficiency. Because it really needs to be based on how a patient wants their journey to happen. Establish a diagnosis, unfortunately, of gender dysphoria. We'll get into that. We have to use that in this country. And then we use an informed consent model. So you're going to go through possible risks and benefits, and people have compared it to like starting a patient on a statin, you know, but there is actually an information sheet we use, but it's not like a legal document. Go through meds and then initial screenings and stuff. So we're going to kind of walk you through this here. So criteria for starting gender forming hormone therapy in adults. So persistent and well-documented. So this or is not true in the US if you're using insurance. So gender incongruence can be used in Europe. It's basically like saying you have red hair. It's like a characteristic of a person. Whereas gender dysphoria is a mental health diagnosis. It's a pathology. It implies distress over gender incongruence. So you have to use that. And then capacity to make fully informed decision, consent for treatment, age of majority, and this number 4, mental health and medical conditions must be well controlled, is a little bit, that's what's changing in the current WPATH guidelines, because often I've had patients with pretty bad anxiety and depression. You start them on treatment, and hormone therapy is the treatment. And it turns out they didn't actually really have anxiety, depression. They actually really had gender dysphoria. It's an accurate diagnosis in that case. And you treat it and it gets way better. So you're not going to get it controlled before you start it. The DSM-5 does have an actual diagnostic criteria, and it's greater than 6 months. It's like their classic of basically, you know, gender not matching how they were assigned, and desire to live in the gender they weren't assigned, et cetera, et cetera. So informed consent is basically, like I say, you could think of it like you would describe, ideally, it would be like you would describe to a cisgender woman starting on oral contraceptives, because many of the risks are sort of the same. But you know, you go through the risks and benefits, you make sure they're really clear on them, And then we have this form. This form is on in that resource guide. It's actually very informational. It's really good. It's actually good. It was good. I enjoyed like having it as a reference to make sure I talked about everything with patients as I was starting. So I would use it. I do upload it into the chart and I give it to the patient. So this role of mental health and gender affirming care has been changing from sort of a gatekeeper role to more of a support role. So you might still want a patient, like if they have sort of extreme mental health diagnoses, or maybe they're not quite sure. Like I was saying, sometimes people have some body dysmorphia and it's a little uncertain if it's body dysmorphia or gender dysphoria. You might still want them to see a mental health specialist. You can have that, you can refer to endocrine and say for mental health in the trans clinic in your referral, and they'll set them up with a psychologist or psychiatrist. So trans-masculine, I'm going to use trans-masculine, trans-feminine because it's a spectrum, really. So goals of masculinizing therapy, there's binary and more non-binary approaches. So this is one of the things when you're asking people's goals, sometimes you'll get people on there, they'll be like, I don't know, I just want hormones, you know, so I'll try to help them a little and say, well, some people want a really binary approach, like they want a full transition or they want to pass, I'll use words like that. And some other people, they want to be somewhere more on the spectrum. They want maybe some changes, but not a full binary change. So that's sort of how I'll talk about it. These are the flags. This is the transgender flag. And this is like non-binary, genderqueer, agender. There's, you know, there's a lot of terms. So what does testosterone do? Does a lot. It's a very powerful drug, I'll say. So I'm not going to go through each and every one of these things, but oops, I thought this one broke it down. So on the psychological front, it reduces gender dysphoria, generally reduces anxiety, depression. There is some sort of brain fog that we see. There's actually a study going on here about the cognitive changes related to testosterone. Some people will start asking, like, can I get assessed for ADHD? I see that quite a bit. Hair. So this is a permanent change. People get facial hair. They'll also lose hair. Sometimes people only want, so hair and voice changes, also permanent, deepening of the voice. Some people, like the people that are more on the spectrum of gender, will just want to grow a beard and to have their voice lowered. And then they're sort of, they're happy. So it's really different. So there's some changes with breast kind of texture. So on the reproductive level, another permanent change is the clitoris size will increase. And then people get vaginal dryness. This can be a bit of a source of actually distress because sometimes people get pain and they don't actually really want to be dealing with their vagina and they're having pain and some issues. Sometimes they'll stop menstruating, and we'll talk a little later about what to do if they don't stop, because most people do want that. You generally get an increase of sexual desire. Acne is very, very common. You want to treat that pretty aggressively. And then muscular changes that you would sort of predict. Sometimes maybe increase in blood pressure. We're going to go through some of these other changes. Actually, I'm going to skip them for now. So on that information sheet that I was sharing for the informed consent that we go through with the patients, it goes through this timeline, which is nice, but you can see here, a lot of the changes start happening at like 6 months, and they can take years to fully complete. But we try to mimic kind of a second adolescence, basically. So this is a bit of a review. So you're gonna really listen and hear what their goals are, especially share the things that are permanent, more likely to be permanent. And then ask them what they know about regimens, what they're thinking they want to use. So generally, it's injections, which can be done, testosterone can be given intramuscularly, which is usually in the thigh, sometimes in the upper outer buttock, or subcutaneously in the stomach. People usually like that. And then there's gel and rarely patches. I almost never see anyone using patches. Cost, sometimes you need a prior auth, and sometimes people are very anxious to get started, and GoodRx is actually quite affordable. So I would encourage that use. So if you're using IM or sub-Q, again, on the one reason to use the pathway is this is all like in there, because it can get a little complicated because into what to order and all that. But basically, the standard doses are to start at 50. You can eat, whether it's cypionate or anathenate, start at 50, go to 100 weekly is generally what you'll do. As sometimes people prefer every 2 weeks, especially if they have a needle phobia, or a lot of my patients that have been on hormones a long time, they go to every 2 weeks. So you can double the dose and go to every 2 weeks. Decanate, we don't have it, unfortunately, here. It's like every 3 months. It's nice. Transdermal, just know that, see these two different concentrations, so you have to know what you're ordering, and it'll be a little insurance dependent what they'll cover sometimes, because some of them come in these little packets and some come in pumps. So again, use those pathways. We worked with pharmacists on them. And then know that people that want to go slow for some reason, or are non-binary, they just want, like, they want to try not to, you can't promise anything. Somebody may go on a whiff of testosterone and things change really significantly. So you do not promise anything, but you start at half these doses, basically, if people are like worried about anger issues or whatever, want to go slow for whatever reason. So this is just on subcutaneous versus IM. You can see the difference in the size of the needles and why you might prefer 25 gauge for subcutaneous. And you get basically all this is saying you get the same levels with the same doses. People generally prefer it. Sometimes I do get, though, people having reactions like some scarring, and you have to change them to IM. So what are some risks of testosterone? Erythrocytosis is, in Colorado, it's not even a risk, it's going to happen. Almost. It's very common. And we'll go into it a little later. Weight gain is common. Acne is super common. Androgenic alopecia, also very common. And I've seen a lot of sleep apnea personally, like in young trans men, not overweight. And then lipids are a little questionable. Cardiovascular disease, hypertension, diabetes there's little like blips in the data. Generally, we think not a big risk, but there are some blips in the data, so it's not 100%. And then osteoporosis is not likely increased problem unless somebody goes off. And then like other cancers, et cetera, needs more study. So don't use this term, transsexuals, but you will find it in the literature. So this is a European study. So in Europe, they use very different regimens than we do and very different patient populations, as you can see. And I'll share some of the differences. And they have these registries, so they can do some of this research. Some of it was scary, some of their research, and a lot of it, anyway, shows up. It's probably some of these differences that are showing up. So if you look there at the percent of gonadectomies, it's huge. I'll show you in our studies, they're way, way lower here. And smoking, really high rates of smoking. And they don't even report, which means they're not controlling for hypertension, hyperlipidemia, diabetes, problematic. And, but they have these long follow-ups. So basically, there's this one study that showed, and we have an updated version of this study that showed an increase in risk of death of both trans women and trans men, but if you look at it more closely, you can see it's malignant neoplasms. So again, there's a lot of smokers. There is this ischemic heart disease. So this does end up panning out in some other studies, AIDS, HIV AIDS, and then other causes. And that's what also shows up in the trans men. And that's it in terms of increased mortality. So this is the updated version of that study. And in it, there in the trans women, there is for both, so they compare it to the general population, basically cisgendered general population of men and women. And again, and then here it's women and men. So they have an increased total mortality compared to both trans women do. And in trans men, you only see it in when they compare to cis women, not cis men. And when you dig a little deeper, you do have this increase in cardiovascular and thromboembolic events in the trans women, and you don't in the trans men in terms of what's driving the mortality. So you see it for the trans men, it's these non-natural causes again. So sort of similar. So what is the cardiovascular risk in trans men? I'm going to skip this because it's not good studies. So this is the blip. So this is the same cohort, this Amsterdam cohort. They basically, this one institution provides almost all the hormone therapy in that country. And you can see here, so this is trans men down here. We'll just focus on that for now. Stroke, myocardial infarction, thromboembolic, using women, cis women as a reference and men as a reference. So you can see that the myocardial infarction, using women as a reference, it doesn't cross. So there was an increased rate of basically non-fatal myocardial infarctions in this particular study. So it didn't show up in the mortality data. It does show up in this. So this is the kind of significant blip of like maybe, why we say maybe it's an increased risk of cardiovascular events. The strong cohort is here. It's a Kaiser study of in 3 Kaiser, Northern, Southern California, and Georgia. Look at their you can see the difference in populations. Current smokers, 24% compared to 40. Overweight, obese, they're accounting for it, and so they're controlling for it. And then the hysterectomy, oophorectomy, 11%. So that's compared to like 88% or something. And then what they did, it's a really elegant design, I think, is they compare to like 30,000, like it's like a 1-to-10 ratio, basically, for every trans patient. There's 10 cis men and 10 cis women. So if we look at the trans masculine cohort, what they did is they looked at the whole cohort, and then they looked at people that had initiated testosterone in the last year, because there's some theory that the first year is the most dangerous. And it all crosses 1. So they did not find a statistically significant increased risk of venous thromboembolism, ischemic stroke, or myocardial infarction. And this is a prospective study, 2006 to 2016. So in conclusion, we think that for trans masculine patients on testosterone, maybe increase in blood pressure, definitely you see some decrease in HDL, and the rest we're saying probably not, but maybe, there is that blip from the Amsterdam study. So there's still more studies that hopefully will come out. So what about other things? So what about aggression? Does testosterone make you aggressive? It's all over the map. 7 studies, 4 of 7 reported increased aggression, 1 of 7 decrease. There's a lot of bias. I actually find I have a couple of patients that are like, yeah, I struggle a little. What they tell me is they are more, they say the thing they're thinking more, which is sort of interesting. A lot of people tell me they actually feel very calm. They feel calmer. They feel more linear and calmer. I've had like 1 or 2 patients struggle with aggression and like they're working with their therapist on it, but they didn't go down on testosterone. Is it safe to continue testosterone during surgery? Yes. Turns out this is a major source of dysphoria because like people might start menstruating again if they go off. A lot of changes start to happen and we used to take people off just recently. And basically in this study of like 310 procedures total, they continued testosterone. There was 0 venous thrombotic events. So we consider it pretty safe to continue. So then what are you going to monitor and why? So before you start, you want to know their hemoglobin and hematocrit because you definitely want to know if it's high before you start because it's going to increase. Testosterone don't check before you start, but you'll check every 3 months after. And we use here that's testosterone LCMS. At Quest, it doesn't matter. Just so you know, it's in those pathways. And then lipids, this is controversial, you know, like at the UCSF guidelines, they say like, as you would any primary care patient, endocrinologists tend to check lipids and an A1C before starting, even in like an 18-year-old healthy person, just because we know it's going to change. It's nice to know, like I have diagnosed familial hyperlipidemia before starting testosterone. And so it was good to get them kind of under treatment before I start testosterone. And then osteoporosis, you really only have to screen for it if they're stopping testosterone and if they don't have ovaries. Primary care, basically use like their organs. If they have the organ, you have to screen. So fertility preservation, unlike trans feminine patients, it's not permanent, the changes to fertility. So I would discuss it, but it is reversible, the changes to fertility. Contraceptive counseling, testosterone is not a contraceptive and it is teratogenic. So really, really important. Like you're going to get like 18, 19-year-old, like they're adolescents, you know? So you have to talk to them and it has to be, I would really encourage you to have conversations. Like, are you having sex with somebody with a penis? Where does the penis go? Like, otherwise you're going to end up offending and you're also just not going to get the information you need to treat them. And then pap smears, just know that it can be very traumatic. What I do, I don't start till 25 because there's newer guidelines that say that, and I don't in my trans masculine patients. I'll ask them, how traumatic will this be? Some patients, they like use their vagina for sex. It's not traumatic at all. And some patients, it's extremely traumatic. So if they tell me it's going to be really hard, they can invite a partner or a family member. I'll give them a benzodiazepine, or you can refer to the trans clinic. Again, endocrine referral to the trans clinic for pap smear, and OB-GYN will do it, that are obviously trans sensitive. And then breast cancer screening, as long as they have breasts, same as a cis woman. Some guidelines that they say to palpate the chest, which I don't do manual breast exams anymore in cis women. So just take that as, just treat them like you would a cis woman, basically. And then HPV vaccine, same as you would. So why the hematocrit? Basically, in this study shows it was 192 trans men. You can see this rise in hematocrit with testosterone. And basically it went up to normal rates for the most part of cis men, but frequently in Colorado, you will find it goes higher, and they're often up certainly above 45, often above 50. I'm a little less worried about this. The reason to check beforehand is like, it's not like you don't have to go running down for JAK2s and things. If it was normal beforehand, you don't have to look for weird things. You just know it's the testosterone. Some patients will feel it. They feel bad when their testosterone is up like 50. I mean, their hematocrit is up around 55, and they will donate blood, or they will do things like phlebotomy. Mostly we try to do other things. So like change from IM and injectables cause more increases in hematocrit. So you can change to topicals. You can do like, if they're on the 2-week dosing, you can go down to 1-week dosing. So it's less, you're not getting those spikes as much. And then I almost always screen for sleep apnea. And this is how I've diagnosed sleep apnea, is their hematocrit shoots way up, and then I end up diagnosing sleep apnea in them. But I'm a little like hematologists are a little like, oh, you just know it's testosterone, and they don't seem to have this 55 cutoff. They're not super scared. We don't know of any documented strokes from it. So I'm a little less scared than I used to be about it. Contraception, just please address it. And unintentional pregnancy rates, 35% have been reported in patients on testosterone. And even patients who have amenorrhea can become pregnant. And it's teratogenic, so important. And then the amenorrhea, most patients want it. You can see that over time, you get a higher percent without bleeding, so it can take a while. And then you see this percent progesterone use. So that's what we use. So in the beginning, I'll tell patients to wait like 6 months. If they're super urgent about it and it causes tons of dysphoria, then I will start a progesterone earlier. And we tend to use agestin. It's a higher dose of norethindrone. So norethindrone, like the mini pill, is 0.35 milligrams. This is agestin is like 2.5 milligrams, 5 milligrams, 10 milligrams. And then ideally you get that down over time to off. So you can see the percent using progesterone goes down. You can switch, again, it's the opposite of the hematocrit. You can switch from gel to injectables. Try to get them at the upper limits of normal. So generally your range is 400 to 700 is the range of testosterone you're shooting for. So get them closer to 700 and they might stop bleeding. And I've diagnosed, you find some patients, I've had patients relatively high levels of testosterone and they're on agestin, 10 milligrams, they're still bleeding. Usually they have a fibroid or something is happening. And so they end up getting a hysterectomy. So these are sort of IUDs I don't use for this reason. They're great for birth control. A hormonal IUD is great for birth control in these folks, but that progesterone is a little masculinizing actually. But it doesn't necessarily stop your periods. It can actually make you bleed more at first. So it's not quite, and I don't know why non-hormonal IUDs on here. I'm not going to go through this. All I'll say on this is contraception options, is just know that combined oral contraceptives is sometimes dysphoria producing, just knowing you're taking estrogen. And it's a little weird to take estrogen and testosterone at the same time. An IUD, if you're just using it for contraception, either progesterone or copper, but a progesterone IUD, I mean, sometimes we'll stop people's menses along, if they're on testosterone, and like I say, it is a masculinizing progesterone. Bone health. So interestingly, if you start older, we see this bump in bone density. You don't see it if you start younger. I think maybe just the bone density is as kind of good as it gets, maybe. And then you don't see a loss over time. So as long as they're on testosterone, you would not screen as just same as like cis men. We don't routinely screen unless you have some other reason. And then post-gonadectomy, like if people do have a oophorectomy, sometimes you can lower the testosterone doses. You don't want to stop it. This is like my patients ask me about this, like, should I have a oophorectomy? Because they're a little bit committing. You want some kind of sex hormone in your body for your bones. So it's you're committing to kind of lifelong testosterone use. All right, so trans feminine hormone therapy. Again, the same things. I'm not going to go through it. Similar with the goals, you're going to ask them, do they binary versus non-binary? Okay, so what does estrogen do? Again, with the psychological CNS, decrease of gender dysphoria, decrease of anxiety and depression, perceived stress, improved quality of life. You don't have those cognitive changes that we see in testosterone. Breast, sometimes there's an increase in breast tissue. I mean, this we get, not sometimes. This is a permanent change. So it's one of the permanent changes. I think this one goes through it. Let's see. Yeah. Skin, this is one of the first changes you'll see. The people will say their skin feels softer, less acne, and hair. Unfortunately, it's not nearly as profound as what testosterone does for the hair. So people say their hair is a little thinner, a little less coarse, but if they want to get rid of facial hair, you have to do something like electrolysis or laser. And reproductive, often decrease in erections. Sometimes this may not be wanted. Yeah, so you have to kind of talk to people about that. Sometimes, I mean, we have given people medications to help with erectile dysfunction if they still want to use their penis. So don't presume they don't want to. Some decrease in prostate size. So they can get sterility, and that is permanent. And so you're talking to like an 18, 19-year-old, 20-year-old trans feminine person. This is a really important conversation because this is a permanent change, and they may be like, I don't want to have kids. I mean, I respect what they say. I'll just have that conversation like 3 or 4 times because sperm banking is not that expensive. So they do want to, if they think they might want to have kids, they need to freeze their sperm. And then skip that. Sometimes decreased sexual desire, some decrease in blood pressure, decrease some of the opposites, basically. And then some changes in body shape. Usually people are frustrated. It's not quite as much as they want. And then no voice change. So this is painful for people. One of the first things I'll do if patients want is to refer to speech. That referral is also in that pathway, speech therapy, because sometimes people will do surgical procedures, but speech therapy is an early thing people can work on. And then again, in that information sheet, it gives the timing. We're again trying to mimic adolescence, and just know that things like breast growth can take 2 to 3 years. And it may not be, sometimes it's nice to talk to people, like it may not be quite as profound as they want some of the changes. So this is similar. So the routes, actually, sub-Q is not a route that's commonly used right now. I don't know why that's there. So, some people are starting to use it and test, but we don't have definitive data on that. So oral, no oral testosterone. There is oral estrogen, injections, patches. And so you can go to talk to people about that. There's no gel. So the dosing, just know this, look at this dosing is 2 to 6. Nobody actually stops at 6. I don't know anyone. The people that wrote this guideline for endocrine don't stop at 6. So we really care more about their ultimate levels. Like the goal levels of estrogen are 100 to 200. Those are on the conservative side of things. Know that when you go over 2, you want to orally dose it twice a day. It's more short acting. And the patches, I almost never start at 0.025 unless somebody is really non-binary. They want to go very, very slow. I'll start at least 0.5 usually. And then the parental, it's Valerate or Cypionate. This is in the UCSF guidelines. They give different dosing, but we don't. And we don't think they're actually like we've consulted with our pharmacists. So same dosing. And you'll see parental more frequently every 2 weeks than testosterone, estrogen. We tend to try to avoid oral in patients that have cardiovascular risks. There's some theoretic, like to avoid that first pass through the liver. So we'll try to go to transdermal if people have some cardiovascular risk or if they're over 40. But of course, oral is the easiest route. And then you'll have people on some kind of anti-androgen. Estrogen, it just isn't enough, basically. There's a lot out there. We'll get a lot. There's a lot in the internet. And actually now UCSF guidelines say that you might want to stagger, but we don't think it's actually on new data, based on new data. We're actually writing to Maddie Deutsch about this. There's a lot of theories about breast growth and what spironolactone does to breast growth. So some patients may ask for a staggered approach. It's fine if that's what patients want to do, but we tend to start them together, spironolactone and estrogen. And then there's this Dr. Powers, who is really against spironolactone and pushes the GnRH agonists. And there's a lot. He has a whole Reddit, and there's a lot on the internet. So just know you're going to get, if people really, really want to dive into this is when you refer them to the Trans Clinic for Endocrine. We don't have this here. It's only in Europe. And so spironolactone, you can push them up to 400, but people will have lightheadedness, dizziness, people have issues. This basically is a big Cochrane review. We're basically at the end on like efficacy of treatment, and the conclusion was none of the studies met their inclusion criteria. So we don't know, we just, so these practices are sort of what we do. Is one route better than another? So this is a kind of challenging slide. Actually, I had to study this slide forever to understand it, and I still don't fully. But one thing I'll point out is, so this is sublingual, transdermal, and injections. And you see the number of the spironolactone doses, average. So the average dose is a little higher in transdermal patches. So that you have to take into account. But then if you see down here, the proportion with suppressed testosterone, which is under 55, it's 100% on the transdermal patch. So we do think the patch, the steady state, actually is more effective at suppressing testosterone. I mean, take it with a little grain of salt, because the doses of spironolactone the average doses are a little higher, but that's something. So feminizing therapy, the goal is development of secondary sex characteristics. Physiologic doses of estrogen are not enough. Big warning, do not use ethinyl estradiol. This is what's in birth control. The early studies of increased mortality, cardiovascular risk at the doses you need is not safe. So do not use ethinyl estradiol. You just use estradiol. And then this notion that maybe oral estrogens are more thrombogenic due to first pass effect. So anti-androgens, I kind of went over this. So people don't usually go over 200 a day, but I have a patient on 400 a day. Like, it's really tolerance. And monitoring, so, well, we'll get to monitoring. You'll be surprised. So fertility options, again, cryopreservation is common if people think they're going to want to have their own kids at some point. Other myths. So people ask about progesterone as potentially helping with breast growth. I've noticed that patients from Planned Parenthood have been coming to me. They just get started on estrogen, spironolactone, and progesterone. Our endocrinologists like to wait a year or two because it actually can cause some thought that it can cause like the breast to be a little more cone-like. And then in my experience, I've had very few patients. I start it. I don't refer to endo. You can, if you're not comfortable, you could refer to endo for this. I'm comfortable starting it, but I've found very few patients actually get a lot of breast growth from it. But what I have found is with micronized progesterone at night, note the at night, it helps people sleep. And so I get patients telling me their mood is a lot better on it, which is so interesting because I think of progesterone as like maybe causing depression and things like that. But I have had a lot of patients who are sleeping better and their mood is better on it. So it's sort of interesting. It can also help suppress testosterone. And then finasteride, dutasteride, sometimes people will want to be on that for hair, reasons for the normal, hair growth and things like that. But just know that it can actually increase your testosterone levels. So this actually applies. I have a trans man who is on finasteride because he's losing his hair. And I let his levels go higher. Like his testosterone lives around 800. And I'm comfortable with that because it's the finasteride is blocking the action of testosterone, but it can actually increase testosterone levels. So the reason we don't use it that much, it can actually cause some depression. And then we don't use it as a blocker because it's hard to monitor because it doesn't lower actual levels. So what are the risks? I told y'all this is a little bit of a dump. Hang with me a little longer. So most likely there is an increase in venous thromboembolic events, likely increase in triglycerides, gallstones, and weight gain, and cardiovascular disease, especially with risk factors, possibly hypertension, hyperprolactinemia. If you get patients, we don't monitor prolactin levels, but if they're telling you that they're getting expressing things from their nipples, then you would check a prolactin level. That's actually from the estrogen, probably. And then diabetes, maybe. Osteoporosis, probably not a problem because they're on estrogen. And we don't know about breast cancer. So we treat, if you've been on estrogen for over 5 years, then screen them like cis women. So increase in ischemic heart disease, likely increased cardiovascular disease, increased blood pressure, increased thrombo. So it's more risky than testosterone. It's a little different conversation. So back to this study that we talked about earlier, that's not the greatest. They're not controlling for everything, but you do see this 1.64 risk, increase of risk I think it's a relative risk, yeah, of ischemic heart disease. And then in this study, which is the updated version, the cardiovascular disease, when they compare to cis men, 1.4, so not that profound, but when they compare to cis women, 2.6. Baseline risk is probably a little higher because it's people transitioning towards feminine. And then I'm not going to do this one, in the strong study, so that's the Kaiser study, you also, it shows up here. So this is the whole population. This is versus cis men and this versus cis women. When they compare to cis men of the whole population, you just see the increase in venous thromboembolic disease. When they compare to cis women, increase across the board, like a ×2. And then when they look at that first year, you see the increase in both compared to cis men and cis women. So it's a real risk. So that's why you have the informed consent. you know. Now it's lower than the risk of suicide if you're not providing this care, you know, so it's just informed consent. And this is the survival curves for venous thromboembolic disease. You can just see this separation happen with reference cis men and reference cis women over time. And the same is true for the venous thrombo. I mean, same is true for stroke. It looks very similar. So what if somebody comes to you and they either have a strong family history of venous thromboembolic disease, or they themselves have had a DVT at some point? So here we have a strong relationship with hematology, and we refer them and have them see them and talk. It's not about, can you start estrogen? Usually it's about how do we make it safe? You know, does the patient need to be anticoagulated, or is it just a matter of let's start a patch instead of oral? You do all the things you can to lower risks. And then for surgeries, you do have to hold estrogen and give postoperative prophylaxis. So similar to, I think I took this slide out actually for the masculinizing and trying to shorten the talk, but you're going to follow both feminizing and masculinizing therapy every 3 months until you're at goal hormone levels. And so for estrogen, it's 100 to 200, and you want the testosterone under 55. And once they are at that goal, then maybe you go to 6 months, and then you can do annual checks. And you're assessing how they're feeling about their care, how they're feeling about the changes, as well as monitoring levels. So that's the reason to actually see them is because you want to know what their experience is. Also, especially patients may start wanting to think about surgeries, other procedures, etc. And so what are you checking? So at baseline, you do not check testosterone and estradiol, but you, at the 3-month intervals, you're checking testosterone, estradiol, and basic metabolic panel, because they're on spironolactone. So this has surprised me, right? I'm an internist. I'm very conservative, actually, usually. Like, I'm the type that if I start like Lisinopril, I want their labs like in a week or 2, because I'm nervous about hyperkalemia. And we check their labs in 3 months. So go up from 100 to 200 to spironolactone, check it in 3 months. They're really generally healthy people. The biggest problem with spironolactone is sometimes people are having syncopal events, or, you know, lightheaded, or side effects from the spironolactone. Lipids, endocrinologists are a little more conservative than I am. If they start high, I will check before we start, just to know our starting ground. If they start high, I'll check again in 3 months. If they don't, I generally don't. I think our guidelines say to, though. And then again, electrolytes because of the spironolactone. And if they go off therapy, you have to screen for osteoporosis. Okay. So what else? So know that they could still get pregnant, even though they could be sterile. So don't forget about birth control altogether. So it can cause sterility, but don't bank on it. So still talk to them about contraceptives. If they have an organ, screen for it. Like, the prostate tends to get smaller, it probably lowers the risk of prostate cancer, but it never comes out. So even if somebody has had vaginoplasty, it's considered a sex organ and like organ of pleasure. So they won't take it out. So just know that. If they have some like extremely high family history or something. And then breast cancer screening, if they've been on hormone therapy over 5 years, screen them like a cis woman is our current. And then again, the fertility. So we used to screen prolactin all the time. Now only if somebody has symptoms. We just use total estrogen levels. And then don't forget about HIV. Rates are quite high, especially so compared to the US population, overall sample of the US population 0.6 reported. This is patient reported diagnosis of HIV. This is in this survey, which is the US transgender survey among trans patients, trans feminine patients, 2.6. And then Black trans feminine patients, 24% reported having HIV. So please, if you're not comfortable prescribing PrEP, refer to ID. You really want to be having kind of what organ is going where, conversations. It's a really important part of primary care for these patients. And then bone health, interestingly, pre-hormone therapy, bone health is less than their cisgender peers, male peers. And we think that's probably societal, like they're not participating in sports. Look what's happening in the world. So probably a societal reason for this. And so it actually improves bone health. Estrogen. So you have the transgender clinic. It's a program here. You can refer to, you just put in an endocrine referral. There's also e-consults for, and just say for transgender care, and try to be specific, like help with diagnosis, psychiatry, or help with hormone management, endocrine. But if you want to refer to plastic surgery, just refer to plastics. So if somebody needs an actual surgery,